Good morning. This is the Cardiac 1 presentation. My name is Hannah Antosh, and this is for Biology 520, Human Anatomy and Physiology 2 with Dr. Brittany Smith. To start off, I want to talk a little bit about electrocardiograms and cardiac events. So an electrocardiogram can either be abbreviated as ECG or EKG. ECG is when the cardiac, like the word cardio comes from the Latin word of cardia. EKG just stands for the Greek, because the Greek word for heart is also cardia, but with an English K or a Greek kappa. For this presentation, I will be referring to it generally as an EKG, as that's how I learned it throughout all my cardiac experiences with my father and my grandfather, but they both stand for the same thing. So an EKG is a medical recording device that is used to record small portions of the electrical current that's occurring in the body. Now, these electrical currents are not necessarily what's occurring in the heart, rather they're the electrical currents that are generated during the depolarization and repolarization, and then are actually recordable on the surface of the body. It's not necessarily all electrical activity. We can use it to represent that. We can think of an EKG like a big picture. It represents the overall activity, but doesn't actually show all activity. It's more of a big picture kind of deal. Rather than a single action potential, it's the big picture. EKGs also can show a comparison in voltages detected on multiple points of the body. A normal EKG has three distinct waves. We have a P wave, we have a QRS, and we have a T wave. So a P wave is going to stand for atrial depolarization. The QRS wave is going to stand for ventricle depolarization. P wave stands for atrial depolarization, and the QRS wave stands for ventricular depolarization. And then T waves are going to stand for ventricular repolarization. So EKGs can provide info on how a patient's cardiac health is doing at that precise moment. And we can use these to record various abnormalities. Abnormalities such as heart rate, abnormalities in rhythm, as well as cardiomyopathies. So cardiac abnormalities can include things such as tachycardia, bradycardia, and atrial flutter. So tachycardia stands for a fast heartbeat. Tachy comes from the word fast. And in tachycardia, the heart rate should be over 100 beats per minute in order to qualify. Bradycardia, however, brady comes from the word slow. So bradycardia is going to stand for a slow heartbeat. And to qualify for bradycardia, the heart rate needs to be under 60 beats per minute. EKGs can also help to detect arrhythmias. And an arrhythmia is any variation from the normal beats or the normal rhythm or the normal sequence. And arrhythmias can have several different origins, such as ectopic foci, alterations in the sinoatrial node, or just conduction interference. My daughter is 4 today, and she has an arrhythmia that was detected when she was 2 weeks old, and we have continued to monitor it every 18 months via an EKG at her cardiologist's office. EKGs can also be used those are heart rate abnormalities. They can also be used to detect heart rhythm abnormalities such as atrial flutters, which are like rapid sequences of atrial depolarization that's going to happen at rates of 200 to 380 beats per minute. And in atrial flutters, the atrium is racing so fast that the ventricle actually cannot keep up with it. Only one out of every 2 to 3 beats, only one electrical impulse is going to make its way to the ventricle, which is very important because if the ventricle received a signal every single time the atria was racing and sent one, what happened is the ventricle could not refill itself back up adequately, which means that oxygenated blood would not be passing through the body as it needs to, and that can lead to a loss of consciousness, brain damage, or death due to severe brain damage because of the lack of oxygen. We can also detect AFib with electrocardiograms. And an AFib is rapid, irregular, and uncoordinated depolarizations within the atria. When you are looking at AFib on an EKG, you will not see definite P waves. The ventricular rhythm is very irregular, and the QRS is normal, but it can look quite sporadic. The lengths of filling filling up the ventricle can vary. So, in that point, inadequate ventricular filling can occur. Along with AFib, there's also something called VFib. And VFib, stands for ventricular fibrillation. And in ventricular fibrillation, multiple pulses are going to travel erratically every direction throughout the ventricle. And when you're looking at an EKG of VFib, that EKG is going to look very sporadic. VFibs are incredibly dangerous if medical care is not received within 4 minutes. This can lead to severe brain injury or even death due to lack of oxygenated blood in the brain. This is because those ventricular contractions are so erratic that no effective pumping is occurring. So that oxygenated blood is not reaching the brain as it needs to. The medical interventions needed with VFib are going to be electrical fibrillation or external cardiac pressure. Next up, we also have EKGs are also very important when diagnosing cardiomyopathies. Cardiomyopathies can look two main ways. We have myocardial ischemia, which is an inadequate delivery of oxygenated blood to the cardiac tissue. We can also see myocardial infarctions, which is also known as a heart attack. So in a myocardial infarction, the cardiac muscle begins to die off. It begins to become necrosed. And that can happen due to blood vessels that either become blocked or ruptured. So my dad had a myocardial infarction called a widowmaker, in which a piece of plaque or a blood clot blocked up his LAD artery. It was a complete blockage, and so because of that, oxygenated blood was not pumping to his brain, which led to a brain death, which is a bummer. But myocardial infarctions also require medical treatment quite urgently. So the study that we're going to, and all the information about widowmakers comes from the Cleveland Clinic. Everything else comes from Sherwood. Sorry. Next up, looking at the study that I chose for this presentation, the study is looking at the relevance of asymptomatic, leisure time. The study called it leisure time sportsmen. What that means is people who are playing sports or are athletes in their spare time. These are not professional athletes. These are people who like to go for a run, maybe like to play pickleball, whatever. But these are looking at these athletes specifically over the age of 35, and looking at them with a coronary angiography as well as resting EKGs and exercise EKGs. And they want to determine the frequency of exercise-induced silent myocardial ischemia. So the participants for the study had to be over 35, and they had to be confirmed asymptomatic by their general practitioner. Exclusionary rules was people with established coronary artery disease or an uninterpretable ST segment due to a bundle branch block. So people who had this already diagnosed were excluded from the study. The study looked at 1,500 fun athletes. 1,205 of them are women. 1,205 of them were men. So 8% men, 20% women. And the average age was about 50 years old, plus or minus 9 years, with an age range of 35 to 80. The physical activity was quantified in weekly MET equivalent tasks. So in hours per week. So it'd be like the MET times duration times frequency. And they got this from the Compendium of Physical Activity, with the range of 0.9 being sleeping when you're not doing activity, to 18, which is running at approximately 17 kilometers per hour. They had 4 main categories thresholds. Number 1 was about 7.5 to about 14.9. Number 2 was 15 to 29.9. Number 3 was 30 to 59.9. And number 4 was at or above 60 in their physical activity scores. For methods, what they did was they did a resting 12-lead EKG that was performed while participants were laying down. So they were watching for variables such as bundle branch blocks or spinal stenosis, or the stenosis. They also were looking for AFib or atrial flutters, as well as STT alterations or premature ventricular or supraventricular beats. That was for the resting EKG. For the exercise EKG, they used the cycle ergometer test, and they conducted this test in the upright position with getting progressively harder, with steps ranging from 200 to 40, increasing it every 2 minutes until the participant was exhausted. The increment was adapted by gender, age, and usual physical activity levels in order to get the maximal predicted heart rate after about 10 to 12 minutes of exercise. That maximal effect was achieved. Subjects, they considered it achieved when subjects hit 90% of their predicted heart rate and blood lactate levels. And the blood lactate levels they were looking at about 8 micromoles per liter, and heart rate was 210 minus their age, and that was what they considered to be that participant's maximal heart rate. For the results, they noticed that the most common issue was obesity. I think they considered that to be over 25 on the BMI scale. 40% of the subjects qualified for that. 63% of the subjects had one cardiovascular disease risk factor, not necessarily meaning that they had it, but they had this risk factor for it. 32 of them had resting hypertension. 13 of them had resting hypertension. 32 of them were suspected of having valvular. I'm sorry, I can't read my handwriting. And they had 16 other cardiac cases. But none of these were considered exclusions because they were either suspected or they were not within the exclusionary criteria. 807 participants were observed to have had variance in the resting category. 684 men and 123 women had a variant observed while resting. They noticed that EKG levels about 1.5. Okay, sorry. 684 men and 123 women had EKG abnormalities while resting. And of that, the most common issue that they saw was an incomplete or bundle block, or some kind of bundle block branch. 67% of all the resting variants, it didn't change based on the age range, what percentage tended to have these bundle block branches. 10 of the resting EKGs were also associated with a suspected cardiomyopathy, and the exercise EKG identified 163 subjects that had an abnormality. 129 of these subjects seemed to have a silent myocardial ischemia, with 34 of them having a severe ventricular arrhythmia or an exercise-induced left bundle branch block. although no cardiac events really occurred during this study. Thank you.